where we are now. So it is 9:13. I am going to turn it over, Dr. Manabe, I think to you or Dr. Landecker to share slides for our 15-minute expert review. And thank you all for your participation in the panel discussion. And if there are questions in the chat, please feel free to answer them.
So are you seeing my presenter view?
Yes.
Okay, perfect. So I'm going to start and then pass over to my colleague, Oliver Leindecker, who is a serology expert and also a diagnostician. So I wanted to start with this. This is, I think, the key. If you're going to take home something, take home this slide, and you can note the citation here in the bottom. This is a way to think about COVID infection. If you think about day 0 as the time that you develop symptoms, and this is week -1 and week -2, let's just say that you get infected sometime maybe a week before symptoms. And what happens if we look at the blue bar here is that the nasopharyngeal PCR will rapidly increase and it peaks sometime after symptoms. But you can see even when people don't have symptoms, they have relatively high burdens of virus. If we look at the pink and the red, these are just other ways to look for the virus directly. If we then look over here at these dashed lines, these are lines from your host antibody response. And sometime around 8 to 10 days, you will develop both an IgM and an IgG antibody response. This is kind of interesting because we normally expect an IgM response to come earlier, but I remember from the early days of COVID, Oliver actually showed this in his lab, and we were both very surprised. But this has been shown over and over again by many investigators. So in this case, it's kind of interesting. So remember, first, PCR positivity, and even in the asymptomatic phase, relatively high burdens. Then in the symptomatic phase, it starts to peak and go down such that most people 15 days after infection will start to be RT-PCR negative. But there are going to be people, particularly immunocompromised, who may have a very, very long tail of RT-PCR positivity. So what are the sample types? You can do nasal, you can do nasopharyngeal, you can do mid-turbinate. I would say that the deeper you go, often the better the viral capture. Mid-turbinate is pretty good and tends to be very well tolerated. That's when you go as far back as a person can comfortably do, and it starts to narrow. Anterior nasal has become the sample type for many of the antigen tests because people can do that at home, where they swirl a swab around both of their anterior nares. The copy numbers are written over here. Throat swabs or oropharyngeal swabs were used for a while. The copy number varies. It can sometimes be as good as nasopharyngeal, but sometimes not as good. Sputum is good for people who produce sputum, but many don't produce sputum. Stool has been used, and interestingly, there's wastewater surveillance going on in the US. Blood is not a good sample type for most things. There is one platform in America that's used on plasma for antigen using a digitized ELISA, which does work relatively well, but is not prevalent. And urine, really, we almost never detect it unless someone has very high kidney burden, but I would not suggest it as a usual sample type. So I'm going to start with antigen assays. These are the most prevalent. Many are WHO pre-qualified. FIND has done a lovely job enumerating all of those and showing which ones have been pre-qualified. Just so a couple of examples to the right that I know are available in India. I want to just remind you how the virus looks over here. So we call it coronavirus because it has a crown of spike antigen. So you would often think spike would be the best target for an antigen assay since you're using an antibody or an aptamer to capture that antigen. But in fact, interestingly, the nucleocapsid, which is on the inside, tends to be more abundant, is shed as the virus deteriorates, and has been in general a better target. There are a few antigen assays that target spike, but not very many. These, so just to remind you, they are mostly lateral flow. So that means that you can see a picture here. You put the sample here in a buffer that usually breaks open the virus, some kind of light detergent, and then it flows across. There will be a control line saying it was an adequate test, And then there would be a test line showing whether or not you have the antigen. It is for qualitative detection, direct detection of SARS-CoV-2, usually nucleocapsid protein, and you do it either in nasopharyngeal or nasal swabs directly. It does not distinguish between SARS-CoV-1 and SARS-CoV-2 because the nucleocapsid protein is not different enough, but that doesn't really matter. We don't have SARS-CoV-1 right now. The clinical sensitivity can be anywhere from 80 to 97% for those that have gotten emergency use authorization in America and WHO qualification. It is not as sensitive as molecular. It usually detects up to what we call cycle threshold values less than 30. So what does that mean? Cycle threshold is as you are amplifying, it's when you can start to detect the target. Obviously, a higher number means it took longer to detect, therefore the viral burden is lower. So it's a little bit the opposite of what you would think. A high number means not as much virus, a lower number means more virus. So for antigen assays, somewhere around 28 to 30, you stop being able to use antigen assays. They don't detect well. There can be some specificity issues, but there is no cross-reactivity with seasonal coronaviruses. Almost all that have been pre-qualified don't have that problem. And readers, if you stick it into a machine and it tells you if the line is real, can sometimes increase sensitivity. But of course, it increases sensitivity at a higher cost. So this is a study that we participated in, and I thought it was kind of a nice thing. We took people who were actually saliva positive, molecular test positive, and then we tested them every day for 14 days. We did antigen tests, nasal RT-PCR, and salivary RT-PCR. So people just drooled into a cup. And what you can see, if you tag to viral culture, so what does that mean? I take that viral transport media and I put it onto Vero E6 cells, the type of cells that can be infected by this virus. And in this case, viral culture kind of parallels infectiousness. So when you're viral culture positive, you'd think that you could give it to somebody else. So if we tag all of these results to viral culture positivity, you can see that antigen's quite good at capturing when people are viral culture positive. Of course, RT-PCR is very good, and this is our molecular gold standard. And salivary RT-PCR is also pretty good. What's interesting, though, is if you look in this pre-positive range when viral culture is negative, or in some cases just turning positive, you'll see that antigen testing is not as good. And so this is kind of interesting in that asymptomatic or pre-symptomatic phase, antigen testing may be fraught with more difficulty, and we'll come back to that. But during the time when they're culture positive, they tended to be quite good in this particular study. And so it gets to the question of, should you do more than one test? Well, to be honest with you, if you are exposed to someone who has COVID-19, I would suggest doing serial antigen testing. You test too early, you risk being falsely negative. And if you don't have access to molecular tests, and even molecular tests can be falsely negative. But I think if you do 2 antigen tests, it may help you know whether or not you really got COVID, because you may not get it right away, or you may be still in that phase where your virus is rapidly increasing. I wanted to just touch on some of the automated point of care test platforms that have been emergency use authorized in America. These are ones that may or may not come to places like India, but you know, India is a place of great heterogeneity. So I wanted you to know that there are point of care tests that are being used, and many of them are fast. So say you're in an emergency room, you really want to know, you're going to take the person to the operating room, or there's going to be something that you're going to do where a lot of people might get exposed. You might want a very sensitive test that you can get quickly. So in this particular thing, antigen tests are down here. They have the lowest sensitivity, but they have pretty good turnaround time, right? But what we're really looking for, an ideal test would be super fast and super sensitive. And so if you look at all of these, the most sensitive tests are up here. The Cepheid Expert, many of you have these for tuberculosis diagnosis, takes 45 minutes, but it's very sensitive. Some of you will have a BioFire. These are expensive tests, though, in general, and will come at great cost. QIAstat is another one, pretty good. Also comes with a lot of different organisms, as does the BioFires. You can say, well, you don't have SARS, but you have flu, or you have parainfluenza. And then there are a bunch over here where they are faster, but they tend to be a little bit less sensitive. The ones that kind of come in the middle are here, and Roche-Liat's pretty good, both sensitive and relatively fast. So think about what your objective is when you're testing. For an individual, you may want it to be very sensitive because that person wants to know the ground truth. What is their status? Why is it important? It can interrupt household transmission. They can isolate themselves. You'd want something that has a relatively good turnaround time, and people's willingness to pay may vary. For public health, I think we want to take people out of circulation who are transmitting virus. And I think antigen testing is a good way to do that. So here, I think less sensitive tests might be okay. Rapid tests that are inexpensive would be more likely to benefit public health. So I just want to remind you, I said this before, SARS-CoV-2's superpower is that it can transmit when the person is asymptomatic or pre-symptomatic. These are data that came out early in the pandemic from the University of Washington. Here you see 3 asymptomatic patients, 24 pre-symptomatic that ultimately went on to get COVID, 4 that had atypical symptoms, and 16 that had typical symptoms. Cycle thresholds that are low on the left-hand side here, showing more viral burden, and open circles showing infectiousness, that they were culture positive. And look here in the pre-symptomatic row, a lot of cycle thresholds that are quite low, and positive cultures showing that these people could definitely transmit to others. And as you get to higher cycle thresholds, they tend to be negative. The scary thing for me, though, is there are people who have relatively high cycle thresholds, not that much virus, but they're definitely infectious. And these people could also potentially transmit, and they would be missed by antigen tests. I think it's worth keeping in mind, but I don't think it changes my public health message from the last. These will be circulated to you, and you can look at some of this other data. But in general, people don't stay culture positive for very long. And it's important to remember sort of the timing after they've been exposed. I also want to bring up kids. So this is the Brave Kids study. Remember that kids can often be asymptomatic, and that's really important. In this study looking at 382 SARS-CoV-2 exposed children, meaning they'd be exposed to somebody who was molecular test positive, 3/4 of them became infected, of course, because this is household transmission. Turns out that having an infected sibling was one of the big reasons to get it. But look here, for those between the ages of 6 and 13, 38% were asymptomatic. And this is why we're really happy that we're starting to see that vaccines in America are going to be emergency use authorized for lower and lower ages in children, because these kids can transmit asymptomatically to others and can be a problem for people who are older, who are more likely to have problems. So with that, I'm going to pass over to my colleague, Oliver, and thanks.
So I'm going to touch on serologic testing. And there are, oh boy, there are many, many, many different assays. And as Yuka alluded to, there's also many different targets. So here we're looking at the host's immune response to the virus, and it could be antibodies directed to the spike protein or the receptor binding domain, otherwise noted here as RBD, and also the nucleocapsid. And there many of the automated assays, so the big machines, the Roche and Abbott machines that are about as big as a small car, those have a tendency to have nucleocapsid, though they've moved to also having the ability to test for spike. And the nice thing here is you can also differentiate between people who've been just vaccinated versus those who've been infected, because the vaccinated individuals, at least for, well, this is actually a US view, because for the vaccines, and I'm not really sure if all the vaccines just target spike, but you can, if the person just has antibodies to spike and not to nucleocapsid, that's a vaccinated individual, versus if they have antibody responses to both, at least at some point in time, they have been infected. Next slide, please. So these tests come in a number of different flavors. Just like there's a rapid antigen test, there's a rapid antibody test. And so here you typically take a drop of blood and it wicks it through, and you can, they have IgM and IgG bands often. I don't think an IgM test is actually that useful. In the past, for a lot of other infections, IgM comes out significantly faster than IgG, but for some reason for SARS-CoV-2, they both really come, they appear at the same time. These are now very good. There's, and we do have ones for RBD, which is nice in terms of also helping to see what the titer, like how much antibody you have. We do, and so there's also ELISA-based assays. This is far better for labs where you can do a lot of high throughput. These ELISAs also come with chemiluminescent ways of detection where you get a lot greater sensitivity. And now we've seen a lot of assays coming to the market which are supposed to be correlated to neutralizing antibody in the sample. We're really looking to see what are correlates of protection, right? What level of antibody, or really any type of measure that we can get, which demonstrate that you're immune to infection or that you have protection against infection. And so those are what, the neutralizing titer and the pseudo particle entry inhibitor assays, that's what those are supposed to do. That work is underway. So yeah, again, unfortunately, there's still a lot of work to be done in terms of figuring out what prevents you from getting infected.
Thank you, Dr. Leyendecker and Dr. Manabe. I think that was a wonderful review, and it highlights nicely what we know, but also what the future needs to be like in order for us to be able to best take care of patients and use our resources. So it is, I think, 9:31. I want to thank all the panelists, all the experts. I know everyone is extremely busy, and the fact that you would volunteer some of your time to do some of this education is a testament to the type of people that help us combat this pandemic. And so thank you for that. I do want to highlight our next session, which will be November 11th, on mental health and COVID-19, which I believe will be our last of this series. And we're going to be pleased to have Dr. Naveen Kumar, who's a professor of psychiatry, leading that session. Of course, we'll be very respectful of everybody's time, but we have a couple more people that I just want to make sure we thank. Dr. Mohanty, Dr. Sharma, Jen Daniel, these are people on the USAID side that can help coordinate if you have questions, and you can see their contact info there. And with that, I will stop sharing my screen, and we will thank you all again. Enjoy your evening, enjoy the rest of your morning if you're with us here on the East Coast, and hopefully you learned something. I know I certainly did.